Hi, welcome everyone for today's lecture. We are very happy to welcome Dr. Murali from Neurology Department. He is Assistant Professor in Neurology. He has completed his DM from CMC and he is working in the Neurology Department. Welcome, sir. Thank you so much for coming for this lecture. Over to you, sir.
Good afternoon, everyone. Today, topic for discussion is approach to brainstem syndromes. The outline will be like anatomy of the brainstem, blood supply, and approach of brainstem syndromes by rule of 4. So, through which we can localize the lesions. And etiology, especially vascular syndromes, and brainstem signs in herniation and coma, and some clinical vignettes. So, coming to embryology of the brainstem, you all know the telencephalon, diencephalon, median, and malencephalon, and from the metencephalon, pons, and medulla oblongata from myelencephalon they are developed. So this is a brainstem ventral view where you can see all the nerves where they are arising from. So this is the brainstem from where the third nerve and the fourth nerve arise, and this is the pons where you have the fifth nerve, and also the pontomedullary junction you have a sixth nerve, and also seventh and eighth nerves are located. And in the medulla, so you have all 9, 10, 11, 12, all will arise. This is the 12th nerve. It is towards more ventral and towards dorsal, all the 9, 10, 11. So this is the dorsal aspect of the brainstem. Here you can notice the trochlear nerve, which is coming from the dorsal side. All the cranial nerves come from ventral side. The trochlear nerve will come from the dorsal side. And this is the little bit cross section. So just to know where the nerves are located and where the tracts are located. So this is the midbrain at the level of superior colliculus. You can see the third nerve, whereas at the level of inferior colliculus, you can see the trochlear nerve. And in the level of the pons, you can see at the upper pons levels, you can see the fifth nerve, trigeminal nerve, and in the lower pons, you can see the sixth nerve, and this is the blue one is the seventh nerve. And the main thing is this is the medulla cross section where you can see the 12th nerve in the medial side, and in the lateral side you can see the vagus nerves. So mainly you have to locate where you have to note where are the nerves arising, which is lateral, which is medial, and what the tracks. And I'll tell you in a few more slides the rule of 4. I'll tell you more briefly which are lateral and which are medial. So this is the blood supply of the brainstem. You can see the medulla. The medulla is supplied by the antispinal artery and also pica, posterior inferior cerebellar artery, and also vertebral arteries. Whereas in the pons, it is supplied by the ICA, anterior cerebellar artery, and basilar artery, and some perforating branches, and supracerebellar artery, and the midbrain supplied by the postcerebellar artery. And what is the role of brainstem? So, role of the brainstem is to provide the transit and posture nuclei for ascending and descending pathways that convey messages to and from the cerebellum, cerebellum, and spinal cord. And also has a part in the integrative functions such as level of consciousness, sleep-wake cycle, muscle tone, posture, respiratory, and cardiovascular control. And the main thing is the action of the cranial nerves, which are composed of sensory fibers terminating in the brainstem and motor fibers originating in the brainstem nuclei. So, few anatomical points we have to recollect. One is the descending motor tracts deficit in lower medulla, whereas somatosensory tracts deficit in the middle medulla. And we have to know that spinothalamic tracts, which carry pain and temperature, are more lateral position in the medulla and pons than the medial lemniscus. The medial lemniscus will carry the stereognosis and the position. And the most ascending spinocerebellar tracts are all are ipsilateral. And all the effects of cranial nerves are ipsilateral except the fourth cranial nerve. And coming to manifestations, multi-system involvement like cerebellum is involved, somatosensory, motor, cranial nerve dysfunction. And lesion of the level of lesion you can know by the affected cranial nerve. So like 3 and 4, you can know the midbrain is involved. 5, 6, 7, 8, pons is involved. 9, 10, 11, 12, medulla is involved. So how you know it is extrinsic lesion or intrinsic lesions? So coming to extrinsic lesions, so you can see that there is successive unilateral involvement of multiple cranial nerves. Here the long tract signs will come later. So more or less like long tract signs. But in the intrinsic lesions, there is a simultaneous involvement of cranial nerves and long tracts. And the second one is there is early involvement of eighth nerve, as in acoustic neuroma, in the extrinsic lesions. Whereas in intrinsic lesions, you have a progressive and bilateral involvement of cranial nerves and long tracts. Like example, infiltrative glioma. And in extrinsic lesions, you have symptoms linked to midline cerebellum, like equilibrium and truncal ataxia. And the important thing is in intrinsic lesions, you have internuclear ophthalmoplegia and vertical nystagmus. And the symptom of raised pressure occurs earlier in extrinsic lesions, whereas in intrinsic lesions, it occurs late. So more you have to remember is long tract signs and also the internuclear ophthalmoplegia and vertical nystagmus. This will more in the favor of intrinsic lesions. So coming to rule of 4. So with this we can easily locate by both longitudinally and also the transverse. So you know that there are 4 structures in the midline starting with M, and there are 4 structures in the lateral starting with S. And the lower 4 cranial nerves are in the medulla, middle 4 cranial nerves are in the pons, and the first 4 cranial nerves are above the pons, the third and fourth in the midbrain. The fourth, and you know that 4 motor cranial nerves that are in the midline, they are divided evenly into 12, means 3, 4, 6, 12. You can divide evenly, but 3, 4 are 12, 4 are 12, 6 are 12. So 3, 4, 6, 12 is in the midline. And what are the manifestations? You know that it is mostly a brainstem syndrome. The patient is having vertigo and diplopia in association with weakness and sensory disturbance. Mostly it may be brainstem lesion. And like dysarthria, dysphagia, ataxia, and bilateral symptoms and signs in the face, and also limbs. More with brainstem lesions. Some other features can also occur with the lesions outside the brainstem. So like cerebellar disturbances, bilateral anterior artery symptoms. These symptoms can occur. So we cannot say definitely it is a brainstem pathology with these symptoms. And cranial nerve palsy with weakness and sensory signs in the face or limbs or cross-sensory lines, cross-sensory signs. This strongly point to the brainstem as a site of the problem. And the pyramidal system, you have what I said before, all start with M. So motor pathway, medial hemisphere, motor nuclei, and MLF. So this is the picture. You can see these are all the medial, these are the lateral. Lateral is S and the M is. So is the MP is motor pathway, ML is medial lemniscus, is medial longitudinal fasciculus, and this is a motor nuclei. So these 4 are in the midline, paramedial. So whereas yes, sympathetic and spinothalamic and also spinal nucleus of trigeminal and spinocerebellar. So these are located in the lateral, these are located in the medial. So by this we can know whether the lesion is in the medial side or whether the lesion is in the lateral side. So this is the, you can see in the same side you have the third, it may be the third nerve in the midbrain, it may be 6th nerve in the pons, it may be 12th nerve in the medulla. In the same side, in the opposite side, you can have a contralateral hemiparesis and a contralateral loss of vibration and proprioception because involvement of the medial lemniscus, and this is involvement of the motor tracts. So because of decussation occurs in the at the medulla level, so this both will have on the contralateral side, whereas the ipsilateral side you can have the cranial nerve pathology. So 3, 6, and 12. So generally abnormalities of pain and temperature very less likely when the medial is involved until there is a like widespread brainstem ischemia. Also you have no cerebellar signs because they're all lateral. But the patient may look ataxia because of weak limbs. And with associated cranial nerves, you can know whether if it is third nerve involved, is the midbrain, the sixth is involved, it is in the pons, the 12th is involved, it is in the medulla. And another important thing is you have to diagnose INO, internuclear ophthalmoplegia. So, although the medial longital fasciculus is in the paramedian brainstem, it is further posted into brainstem, usually not affected by the occlusion of paramedian perforating vessels. So, isolated involvement of medial longital fasciculus, mostly in multiple sclerosis or some lacunar infarcts. So, in the internuclear ophthalmoplegia, you can see here the MLF leads to failure of adduction in the same side, ipsilateral side. There is a failure of adduction in the eye. In the contralateral eye, they will have a abducting nystagmus. So, this is one of the feature. By this INO, we can know it is intrinsic lesion, and by this now we can know also it is in the medial part. And the anatomy of the lateral brainstem. So there are four structures, what I said before: spinothalamic pathway, sympathetic pathway, sensory nucleus of fifth cranial nerve, and spinocerebellar tract. So with this, so in this also you can know that the ipsilaterally, what is involved? Ipsilaterally you have a cerebellar ataxia, and ipsilaterally you can see the involvement of the face, means involvement of pain and temperature in the face. And this is a contralateral pain and temperature in the upper limbs or lower limbs on the trunk. So this is because of ipsilateral involvement of the fifth nerve, ipsilateral involvement of the parasympathetic, and ipsilateral involves spinocerebellar tract. So you have ipsilateral Horner's, you have ipsilateral sensory pain and loss of pain and temperature in the face, and also ataxia. On the contralateral side, you have loss of pain and temperature on the contralateral side in the upper and lower limbs in the trunk. And this is, and you have to localize according to the cranial nerves. So fifth, seventh, and sixth, you can know it is pontine syndrome. As 9, 10, and 11, you know it is medullary syndrome. So by this pattern, you can know whether it is lateral or medial, and that is by the horizontal. You can localize horizontally. By the knowing what which cranial nerve involved, you can know there is the level of the lesion. So on this, we can know the patient can have a Horner syndrome. So you can see have a meiosis, and you have an anhidrosis, and also ptosis. So you can have a Horner syndrome whenever the patient is having involvement of the lateral side of the brainstem. So according to the nerves, like 9 and 10 and 11 involved, you can have hoarseness, dysarthria, dysphagia. Whereas the 5th and 7th is involved, you can have the facial weakness corresponding to 7th nerve, and weakness of meset and pterygoid corresponding to the 5th nerve. So you can know it is 5th and 7th is involved, it is pons. 9 and 10 is involved, it is medulla. So 8th nerve is very rarely affected. Coming to etiology of the brainstem. So most of the brainstem lesions, the most common etiology is vascular. So the brainstem is the most frequent cause of the acute brainstem lesions, and most syndromes have been described as a sequel of brainstem infarcts, like Weber, Martingale. All these symptoms are described by the sequel of the brainstem infarcts. Ischemic ventricular strokes account for 23% of all episodes. These 48% of these affect the brainstem. Involvement, most common involvement is pons, 27%, and medulla is 14%, and midbrain is 7%. And other non-vascular disorders, etiology, which is causing the brainstem, or demyelinating, which mostly we deal with multiple sclerosis and EDEM and NMO, neuromyelitis optica syndrome, and degenerative diseases like Parkinson's supranuclear palsy and multi-system atrophy and trauma, and also tumors like brainstem glioma and brainstem encephalitis like Bickerstaff encephalitis, and central pontine myelinosis and Ornard-Chiari malformation, syringobulbar. So this all the etiology is mainly depends upon the what is the localization and what is the temporal profile. So the patient is acute onset, you have to look for more of vascular, and if the patient is having subacute, you have to think of more of an inflammatory infection. Whereas the chronic, you can think of a tumor and a nutritional. So most common is vascular syndrome. So what are the common what we dealt before? This is the common which area is involved. So it is in the, this is the medulla. So it is the lateral medullary syndrome, and here there is a vessel. This is the pica is involved, and these are the these are all involved. So that is the uh, 9th and 10th and spinal. What I said before, spinothalamic and sympathetic tracts are involved. The lateral medullary syndrome, and these are the symptoms. So you have the contralateral. This is the left-sided lesion, left lateral medullary syndrome. So you can see on the ipsilateral side, you have a Horner syndrome, and also loss of pain and temperature, and also opposite side pain and temperature, and the ipsilateral side ataxia. So what I said is before the same thing, just illustrating in the picture. So this is the Horner syndrome. These are the left-sided medullary syndrome. So contralateral pain and temperature, and ipsilateral Horner's, ataxia, and loss of pain and temperature in the face. This is the medial medullary syndrome, and the affected is the anterior spinal artery. You can see here. So these are the motor tracts are involved. Motor tracts are affected, and medial lemniscus, which carry the positional stereognosis, in the 12th nerve. So this is involved in the medial medullary syndrome, and this is the picture where you get it. So you have a contralateral weakness, and also loss of joint position sense on the contralateral side, whereas ipsilateral side you can have the INO, internuclear ophthalmoplegia, and also deviation of the tongue. Here the deviation of tongue towards the same side. It is a left-sided medial medullary syndrome. So tongue is deviated to the same side, and you have internal ophthalmoplegia on the same side, and also opposite side you have a weakness and also loss of joint and position cells. So this is the lateral pontine syndrome. Here the affected is ICA, anterior cerebellar artery, and the same type, all the SS are involved on the lateral side. Almost the same thing like a lateral medullary syndrome, ptosis and this INO, ptosis, Horner syndrome, and ataxia on the same side, contralateral pain and temperature. Here only we differentiate with the involvement of the cranial nerve. So either if the sixth nerve is involved, we can know if the pons. If the seventh nerve is involved, it is in the pons. Based on nerve involvement, we can know where is the localization. Otherwise, the traction is the same thing. This is the medial pontine syndrome, and is the same thing, almost the same thing. In the medial pontine syndrome, internuclear ophthalmoplegia on the same side, and also the joint position sense, and also weakness on the opposite side. And this is the ventral pontine syndrome, where you can see you have affected the medial lemniscus. These are the medial lemniscus and some motor tracts. So you have both entire involvement of the patient is in quadriplegia, numbness, and because of this is like a locked-in syndrome. Because the reticular system is in the dorsal area, the patient will be conscious. The only movement they can do is they can blink the eyes, and they can move the upward gaze is present in these patients. Coming to the medial midbrain syndrome, you can see these are maybe the cerebral artery damage. You can have a median midbrain syndrome. Here also you can see the tracts are involved, and also the third nerve is involved. So you can have the weakness on the opposite side, and you have the eye involvement. In the eye, you can see eye is down and out, and is a dilated pupil because of the third nerve. So ipsilateral side you have a third nerve, eye involvement. Contralateral side you have a weakness in the medial midbrain syndrome. Whereas in the lateral midbrain syndrome, you have the same. Here third nerve is involved, but here the difference is there is a rubral red nucleus is involved. So you have a tremors. So patient is having a contralateral tremors on the opposite side. On the same side, you can have a the eye is out and out, and it is dilated. So most all the Brainstem syndromes say to see first eye, because the eye is more important. If you have Horner's or INO, Horner's is lateral, INO is medial. So by this we can know where is the lesion, and also in the midbrain you can know if it's a dilated, eye is out and is dilated, it is in the midbrain. So this is the involvement. There is a superior colliculus involvement in the dorsal side. So in this RIMLF, this rostral medial long-term fasciculus is involved. So there is only upgaze is involved. Upgaze is patient can't look up. So this is only the sign we can see in this syndrome, in dorsal midbrain syndrome. Maybe in the pedioloma can have this dorsal midbrain syndrome. So in summary, you have to remember the rule of 4 and distinguishing cranial features of each syndrome. Then we'll be able to identify the presenting syndrome and localize the stroke to a vascular territory. Now I'm dealing with a lot of confining the brainstem herniations and what are the symptoms and signs when the patient is having a brainstem herniation. So this is the central herniation and this is the uncal herniation. These two I am dealing with. So in uncal herniation, you can see patient is having ipsilateral anisocoria. So because involvement of third now, the people will be dilated and the patient will have a contralateral motor weakness following the uncal herniation. Sometimes if occasionally there can have notch phenomena, can have a ipsilateral weakness. So when the patient is having anisocoria with contralateral motor weakness, we have to suspect the uncal herniation. And next one is and some patients with the, if it is uncal herniation is more, they can have a lateral shift and they have a compression of the diencephalon leading to altered sensorium due to distortion of the reticular activating system, and they can have a hydrocephalus due to obstruction of CSF pathways. Coming to downward transtentorial herniation. So initially patient, how we know the patient is deteriorating? First the patient will have the decorticate and then progress to decelerate postly along with the loss of brainstem reflexes, and the patient may develop a kinestroke pattern of breathing, and finally will lead to fixed dilated pupils and respiratory arrest due to compression of the medullary respiratory centers. And the brainstem in coma. So the most common causes of the coma is one is involvement of hemisphere, and another is involvement of the thalamus and brainstem compression. So diffuse hemisphere may be the cause of trauma, ischemia, hypoglycemia, and bilateral thalamic can be hemorrhage and infarction. Brainstem compression may be supratentorial or infratentorial mass lesions. So this is the clinical assessment of the coma, which we generally do the general examination, neurological examination, and the level of consciousness, Glasgow scale, and the motor function, and the brainstem function. So this is mainly a concentrated brainstem function, like you have to see the pupillary responses, spontaneous eye movements, oculocephalic responses, and caloric responses, and corneal response. Each one has a localization value. So when you have bilateral hemisphere dysfunction, they have symmetric signs, may have fits or myoclonus. They have normal brainstem reflexes and normal oculocephalic reflexes, normal pupils. Whereas patient is having supratentorial mass lesion like uncal herniation, they have ipsilateral thorno palsy and the contralateral. Yeah. So the patient is having disconjugate eye movements. It will imply the sixth or third nerve or intrinsic brainstem lesions. Skew deviation occurs in the posterior lesions. And then the patient in coma, if has spontaneous eye movements, like a roving eye movements, you can know that the third nerve nuclear connections are intact. And some patients, because of irritative or epileptic foci, they have a contralateral conjugate eye deviation. And ocular bobbing, it is a rapid downward jerk of both eyes, slow return to the mid position. This movement is specific for acute pontine lesions. So by this we can localize where is the lesion and we can know which is not involved based on the movements. So this is the ocular cephalic movement like doll's eye. So normally when you turn, the eyes turn to the one side, to the left, the eyes will turn to the opposite side. So that is normal. If the patient, the eyes are not moving, it is abnormal. So if ocular reflex is absent, it tells about there is a brainstem dysfunction. If the ocular cephalic doll's eye is not present, then you can go with the caloric test. So normally when you give a cold water, there is slow movement towards the ear where the cold water is infused. So the patient is the eye is not moving towards the cold water. So it tells us that there is a brainstem dysfunction. And this is what the routine when we check for the motor, when you give the stimulus to check the motor and GCS. So in the hemispheric lesion, you have the flexion of the upper limb like in the decorticate, and the subcortical in the hemisphere, you have a flexion position, whereas in midbrain and pontine medullary lesions, you have a D-separate position where you have the extension of the upper limbs. So some case scenarios. So 27-year-old gentleman from Gudiyatham who is apparently normal till 5 days, 5 years, presented with recurrent episodes of right eye visual loss followed by progressive ataxia. So on examination, there is a right eye visual acuity of 6/18 with RAPD and the cerebellar signs on the right side. So because of young chop and he is having recurrent episodes with eye involvement and also the ataxia, the localization is the optic nerve and also cerebellum. So initially we suspected to have a because of young chop and with recurrent, we thought of more of a demyelinating lesion, and we went with the MRI. So in MRI, there is a classical picture of there is the flare T2 hyperintensities in the ventricular, periventricular, and in the brainstem, and also the right MCP is involved. And we did a spine imaging where we have a short segmented lesions. So it turned to be a multiple sclerosis. So this is the radiological features of the MS and the NMOSD. So in NMSOD, this part of the optic nerve and optic chiasma is involved. In moth, the anterior part is involved. In the multiple sclerosis one is a part of the optic nerve is involved. And in the spinal cord, you can see in the NMSOD is a long segment involvement. This is a more than 3 vertebrae should be involved. And in the moth, there is a conus involvement. And in the multiple scale segment, there is a short segmented involvement. And you can see in the exo section is almost entirely involved. Is more placed in the central, whereas in the multiple sclerosis is more in the peripheral region. And you can see the NMO, all the periventricular is involved in the NMO, whereas in moth, there is involvement of basal ganglia, there is involvement of thalamus, and also infratentorial involvement. Whereas in MS, you can see these are the dorsal fingers above the corpus callosum. So there is involvement of the corpus callosum, there is involvement of periventricular, and there is involvement of cortical, subcortical, and there is involvement of U fibers. So this is one difference between NMO and MS. So there is involvement of U fibers in MS, and the patient is can have involvement of the infratentorial. So these are criteria for MS is cortical, subcortical, periventricular, infratentorial, spinal cord involvement. So another guy, 45-year-old gentleman from Jharkhand, present with a recurrent cranial events, CNS involvement in the form of intractable hiccups, vomiting, and non-progressive dysphagia. He showed improvement in strides, followed which he had a stiffness and tightness involving the left lower limb along with painful paresthesias. So examination is having bilateral optic disc failure and left lower limb spasticity with exaggerated deep canal reflection in human bladder. Again, the localization with the hiccups is the area posterior and the cervical cord, left-sided cervical cord. So the imaging you can see is a medulla. So both the dorsal and ventral part are involved. So area posterior is involved. This is the cause for the hiccups, and you can see the axial section of the spine, where you can see the involvement of almost half of the cord is involved. Is more likely NMO spectrum disorder. Another 40-year-old gentleman presented with acute onset vertigo and vomiting. On examination, he had a left side Horner's and left 9 and 10th cranial palsy and left cerebellar symptoms. So, like what I said before, so the patient is having Horner's and also left cerebellar symptoms more on the lateral side. So, and you have a 9 and 10. 9 and 10 is medulla. So, it must be the lateral medulla. So, we have taken. So we have done a stroke protocol, which you can see the infarct in the lateral medulla. So this is the DWA showing the hyperintensity, and at the same time we have density showing the DWA, and in MRI showing we are unable to see the vertebral artery. So this is the lateral medullary syndrome. So another 53-year-old patient present with the acute onset vertigo, followed by the horizontal diplopia to the left gaze. He did not have any other comorbidities. Patient on examination has a left gaze palsy. So the clinical localization was to circulation involvement of gaze pathway. So medial longital fasciculus. So we did MRI. The MRI was these are actually outside MRI. And they have done a stroke protocol where you have seen the infarct in the medial longital fasciculus in the midbrain. Coming to case 5, 53-year-old patient present with acute onset vertigo. Sorry, case 6, 30-year-old gentleman present with recurrent neurological deficits since 2021, involving the brainstem and thoracic cord, which were responding to steroids, but did not start on the second line immunomodulation. He presented with weakness of all 4 limbs with bilateral ophthalmoplegia, ptosis, and bulbar dysfunction and decreased responsiveness. So with the bilateral ophthalmoplegia, ptosis that means the midbrain, and bulbar with the medulla, decreased responses is due to reticular activating system. So all is localized to brainstem. We did a CSF analysis. CSF is showing the 7 proteins and the protein of 297 and all the negative infectious screen. His CT thorax, the abdomen was normal. His immune markers, NMO, all became normal. HLA-B51, biceps also negative without of inflammatory infection, and the tumor all came negative. Currently he was on treatment. So his MRI, you can see his MRI. There is a diffuse involvement of the thalamus, midbrain, and also brainstem. Whole of the brainstem is involved with the thalamus, and also you can see the cord, cervical and thoracic cord is involved until the conus. So we are treating. We didn't have any positive in the workup. So we're treating like a immune mediated because previous response with steroids, and he was under follow-up. And 65, next case, 65-year-old gentleman present with a subacute onset gradually progressive weakness of right upper limb, lower limb with a spasticity and the right human facial palsy with intermittent loss of awareness and supranuclear gaze palsy. So because of supranuclear gaze palsy, we can localize to midbrain, and the intermittent loss of awareness we can localize to thalamus. So this patient had a large T2 hyperintensity lesion involving the midbrain and also parietal area, and this is the contrast which is showing heterogeneous in the same area involving the thalamic area. So on MRS, patient is having elevated lactate and reduced NSTL with choline reversal and the lipid lactate peak. So it is a more of a tumor. So we are thinking more of a glioma, and we refer to neurosurgery. So coming to case 8, is Tamin, 25 years old, present with 50 days history of headache and altered sensorium. On examination, the GCS was E4, V2, M2, and there was a neck stiffness without any localized insights. So considered to have subacute meningoencephalitis, and CSF showing a lymphocytic flares with low glucose. You can see this MRI. So MRI, you can see the flare where you have T2 hyperintensities and also the infarcts in the basal ganglia area. So this is causing a and we have in the contrast you can see the leptomeningeal enhancement. So in view of the history and the imaging, most we treated like a TB, but only the CSF TB was not negative, but bone marrow TB came MTB trace positive. It was an ATT. Thank you.
Thank you, sir. Thank you so much for this time. Anyone has got any questions? If there are no further questions, anyone has any questions? This question, can you please explain on 1.5 syndrome?
Yeah. The middle articular fasciculus is involved, so the patient cannot adduct, and also the PPR is involved. They can have a horizontal gaze palsy. So both horizontal gaze palsy and also the patient can all adduct the one eye. It is 1.5 syndrome. Mostly it occurs in the whenever the MLF lesion or PPRF lesion, when you have a 1.5 syndrome, mostly in the multiple sclerosis.
Any further questions? If there are no further questions, we'll end the session. Thank you so much, sir, for coming and taking this lecture for us. Thanks, sir.